Good evening, everyone. It's great to see so many familiar faces in here today. I just want to present it, just to report it back for the CAHR conference. I went in the CAHR conference as a participant. So instead of a presentation, maybe I can perhaps having a little bit conversation with all of you, and at the same time, just to let you know what I observe and what I listen to throughout the conference. And then my colleagues, Christian, will leading you into some major presentation. So I start off saying the CAHR conference is the 32nd years hosting this event. This time they're hosting it in Quebec City. If anybody never been to Quebec City, I would recommend them to go for a visit. It's actually beautiful. And the date of the event is starting from April 27th to April 30th. Even the city is very nice, and I'm sure that Christian agreed with me, the weather is still a little bit cool. So we don't have much chance to really sightseeing the city, except, really get into the conference on different dates. So overall, what I feel about the conference this year, a lot of focus on access to care and health equity. So many of you are community members or researchers or presenters. You know that, access to care and health equity is very important. And many presenters at the CAHR conference also mentioned and focusing on the same idea or topics. We consider ourselves living in Toronto is, could consider it's more like luxury or privilege, because we have a lot of primary family doctors, also primary care of HIV doctors, specialists in HIV. We have lots of hospital and a lot of pharmacy. But imagine if you are living in the suburb, let's say not too far away from us, Thunder Bay, Sault Ste. Marie, people who are living with HIV or people who are 2S LGBTQ, if they want to seek a physician who are familiar with the community or HIV, they don't usually happen just like flipping of fingers. So they find it very hard to navigate the system in the suburb, not finding the right doctor, and also think about if you don't have too many shop for drugs or independent pharmacy. So if you want to, dispense your ART, your HIV ART, your antiretroviral, it will be a little bit more challenge. On top of it, it's also the traveling time. They find out sometimes you cannot just hop on a bus and go to see your doctors or, getting your prescription refill. They usually travel for quite some time. So I think the whole healthcare system and also most of the research at the CAHR conference are focusing on access to care. And in terms of health equity, is people who are racialized or marginalized or living in a social determinant of health, which is, income security, food security is a problem, or even housing. They don't find the service, the healthcare service they receive from either their healthcare provider or service provider is as equal to people who are not living in the social determinant of health, which they have normally stable housing, stable income, stable food supply. So there is a comparison between people who are marginalized and racialized, living with especially the BIPOC community, the people of color community, like the African, Caribbean, Black, Asian, East, South Asian, or the Latin or the indigenous community. They find it a little bit challenged to communicate or to have an equal access of healthcare compared to the mainstream. So I just want to bring this to all of you that health equity and access care is pretty well the main focus at the conference. So next things I observe in the opening session is two things. I really want to quickly mention it. We recognize and acknowledge the achievement of two individuals. One is Mr. Chris Bunting. He used to be the CEO, the former CEO or executive director at Canadian Foundation of AIDS Research, CAHR. Unfortunately, Chris passed away, but he is the man that really advocate for self-testing kits. And fortunately, he can witness the self-testing kits launch before his passing. So Mr. Andy Pringle, his brother-in-law, was actually presenting this award to Mr. Chris Bunting. I don't know if I make a mistake. It was actually also partly to do with receiving the award or presented the award along with CAHR. Another person that I really do admire is Miss Joanne Lindsay. I'm sure some of the community members already met her in many events, especially she is a very advocate for women's people living with. She do a lot of work at PWA, and also she was one of the researchers along with Dr. Anne Bushell on women's and ovarian cancer and HPV. She wasn't well. She wasn't there at the award, but after years that according to, especially in the issue, I really serving this award. Now back to some of the conference that I attend. One of the abstract is an oral abstract. Is talk about peer navigation. So as a peer navigator, I'm sure many people know what peer navigation means. Usually when you accompany someone to doctor's appointment, make sure they are safe. You can do some translation if they have the language barrier. Maybe at some time you can help them to, in terms of legal services or referring or doing some referral. But when I listen to these two ladies in the oral abstract, they are from BC. These two ladies talk about, the peer navigation work should be in a clinical setting too, meaning should be have peer navigator who are living with HIV, working in the immunodeficiency clinic or in a hospital setting, or as well as I would say a clinic that is serving people living with HIV. And they also mention it's no, big surprise to me. They should not use peer navigator, using peer as a token, where we should pay peers well enough to do a good work. Why they keep on saying that they should have peer navigation is so important role because it's building the trust amongst peers. So if you are also living with HIV positive, you disclose your status to someone who are newly diagnosed, it will certainly build some trust. And they totally agree with it. And they should also mention it that clinic or the hospital or institution should work alongside with any AIDS services organization. But having said that, they're really pushing it to having some peer navigator in a hospital setting or clinic. And I do believe years ago, they have some sort of a project, do it in Hospital St. Paul in British Columbia, but I don't hear it in this oral presentation from them. So I don't mark my word for that. The second thing is also, again, another oral presentation from BC. I find it interesting. This young man who was researcher, not man, I would say, young researcher, was talking about STI PEP. Everybody heard about PrEP. PrEP is a medication and a routine for prevention of HIV. But since many people are not living with HIV or using PrEP, I guess when they come to sexual activities, they can be at risk because you don't wear a condom, or your sexual behavior can change a little bit, your attitude change, you're willing to take some risk. And then they say, oh, I won't get HIV. But at the same time, you mostly will get STI, sexually transmitted infection. And recently in Canada, all different STI is the number going up, especially syphilis and gonorrhea. So this researcher was doing some survey and interview and conduct a research, asking the BC residents, what do you think if you want to have an STI PrEP, some sort of a medication that if you think you are at risk getting an STI, instead of going to see a doctor, you have to wait for a few days or do some testing. You can pop a couple pills, 2 to 3 days. At least you can prevent any seriousness or danger in any STI virus. So I think it's interesting, and I kind of supporting it, because at the same time, if you happen to go to see a doctor, you might be judged by the doctor. Oh, are you sexually sexually active, or are you very dirty? However they want to judge you, right? And at the same time, you might have to wait for a couple of days in order to get the medication. So imagine if you know that you have sex and you think that you're at risk getting STI, you pop a couple of pills on your own, which is prescribed by the doctor. That will be a new era for the community and for society as a whole. So I think this idea is very good, but how it comes through, we have to be wait and see what happens. Lastly, I want to talk about CMV. CMV is a virus back in 1980s. This is when I was diagnosed, right? Usually CMV is, well, at that time they call it SNI disease, right? Chorioretinitis, excuse my pronunciation. So it's a immunogenic virus. So they can hide in your body. But back in the 80s, a lot of people have CMV is usually attacking the eyes. And you see some floater. You get little, when you see, you get a little bit like a floater, a little bit like a balloon, little tiny bubble in front of your eyes. And when in the 80s and 90s, when you have CMV, they say, oh, that's mean this person living with HIV usually have a compromised immune system, which is less than 300 or 200 to consider very low at that time. But because of the ART that we are receiving right now, we don't heard about people talk about CMV anymore. Everybody seems to live in a normal life, can be very happy, even you're living with HIV, you can work and so forth. But in this presentation that I was attending, this doctor was talking about, well, CMV is slowly creeping back up. Not just happening to MSM, men have sex with men, or just men. It happens to women's children, but it's not usually attacking your eyes. He said it also, the first things that they really can get the symptoms is in in your gut. Normally you have diarrhea, you have infection, the diarrhea doesn't seem to stop. Sometimes you don't feel your heart is really pumping very well. So some cardiovascular problem at the same time. And they also find CMV lately can be detected in genital fluid, saliva, mouth, all these things. They can find some CMV virus in the test within the genital fluid, mouth, and saliva. So they keep on saying that we should get tested CMV once a year or once every 6 months as your doctor, because it's still treatable. But if you're not taking care of it, the CMV virus, actually the antigen, will get into your HIV virus and create more inflammation for people living with HIV. So meaning that it will cause you more, maybe just some opportunistic infection. The worst things they foresee is some comorbidity if you not tested with CMV. So when I listen to this presentation, I encourage everyone, maybe once a year, should ask your doctor to do a CMV testing. This is what I observed at the CAHR conference, but the main bread and butter, I will leave it to Christian to present it to all of you. Thank you for listening and enjoy the rest of the evening.
Thank you so much, Kenneth, for the wonderful presentation. I just wanted to pause there to see if anyone may have questions to ask Kenneth first, because I do have a number of updates to report back to you. And if not, then maybe I would just go ahead with my presentation for now. But feel free to stop me at any time if you have a question. So like Kenneth, the CAHR conference is a fairly big conference. This happens annually. It's the National HIV/AIDS Conference. So I actually, took part in the conference, and also there was a pre-meeting that the Canadian HIV Trials Network holds, twice a year. And that meeting, the CTN Spring 2023 meeting, took place right before the conference. So I'm just going to talk mostly about what took place at the CAHR conference, but I'm also going to talk just about one session I engaged at the CTN Spring 2003 meeting as well. So the CTN Spring meeting, I was invited to speak at one of the sessions led by the clinical and care management team. And they were talking about the CAPLA, so the cabotegravir long-acting injectables. And what the session was focused on was about access. ACAS actually had previously held a presentation on the topic earlier this spring. And if you're interested in learning more about CAPLA, please, go to the ACAS YouTube page to find out to review the wonderful presentation about how CAPLA actually works. And I believe the presentation was led by Dr. Alexander at the University Health Network. So for the CTN meeting on session on CAPLA, it's really about kind of talking about the issues around access, how as newcomers or racialized communities, whether there's adequate support in place to support service users to get access to CAPLA. I myself am not on the long-term injectable, and I actually, feel pretty good with, using my current regimen. But for many who may have difficulty adhering to the treatment, CAPLA actually is a good alternative. I was one of the panelists from the community, along with Hawa from the AIDS Committee of Ottawa. So it's interesting that to learn, in Ottawa, at the AIDS Committee of Ottawa, they actually bring in, healthcare providers to do the injection there on site. So, talking about the seamless continuum of care, that actually is quite helpful. And one of the researchers who presented on the topic actually said, he was able to get a widespread in terms of racial, ethnic diversity of whom he was able to introduce CAPLA to. So, and that's amazing because, a lot of times these newer biomedical interventions do not reach communities such as, ours. And how, the doctor was able to reach, the Black African and Caribbean communities is because they were actually, they collaborated with ACO on, providing this easy access for community members to, to get the injection and to have follow-ups. I actually wanted to thank many of the ACAS members who attended the C+25 presentation on CAPLA because, a lot of what I, offered during that day was actually feedback that I heard from many of you. So I just want to note that. Thank you so much. Okay, so in terms of the other sessions, so prior to the actual CAHR conference meeting, there were ancillary sessions. So these were kind of the satellite sessions that took place prior to the actual conference. One of the ones that I attended was focused on HIV and chronic pain. And this seems to be an emerging topic that, got community members talking and a lot of, interest from researchers. Some of the key themes that came out from the session included that for people living in HIV, especially those who are aging or have various comorbidities, they find that there's actually not a lot of awareness amongst healthcare providers on their pain conditions. And when they do reports that they experience pain, they're kind of just, I suppose the healthcare providers are not taking their conditions seriously, and especially if they are requesting, for pain medication. And this can be problematic because, our communities are very diverse. Many of us, may have various, life challenges and struggles. Some may, be using substances to ease their pains. And when you talk about pain, it can be, beyond just physical pain. It can be psychological pain. It can be pain related to trauma. So, and given the, I think current overdose and drug poisoning crisis that's happening in Canada, I think a lot of the medical providers are hesitant to prescribe pain medication. But by doing that, that actually deny a lot of the people living in HIV their rights to, address their pain conditions. So The session also included presentations from the researchers and also community members with living experiences. And they kind of noted it's important that this issue be addressed within the healthcare delivery system, because there's significant gaps in ways how people living in HIV and chronic pain are being received. And there also needs to have clinical guidelines to support, medical professionals to provide better care for people living with HIV and chronic pain. Another ancillary session that I attended was on HIV molecular surveillance. So HIV molecular surveillance is a public health tool. So a lot of times when you go to get your blood drawn for your blood test, what happens is that these samples goes to the laboratory, and HIV molecular surveillance is a tool where they actually look at the blood samples to see if there's any resistance that may be happening. Let's say you're on medication should work and suppress your virus, but sometimes there might be treatment failures or viral breakthroughs. And the intention of HIV molecular surveillance was to kind of create these alerts. So when that happens, then medical providers or public health can be aware. And so sometimes they talk about finding these clusters where treatment failures might be happening. However, on the other side of the coin, there's actually a lot of ethical concerns that takes place, because a lot of times when you go to a blood lab, people don't actually really know where your blood goes beyond the lab. And, sometimes, people are also unaware that, some of the researchers might be doing research on these types of blood samples. So, for example, in the US, because the US national HIV strategy actually had placed the usage of HIV molecular surveillance as one of their priorities in terms of preventing, viral breakthroughs or whatnot. So there were researchers that were actually engaging in research of people's blood samples. But when the community found out about this, that caused quite an uproar within the community. And luckily, the researchers actually listened to the community and paused the research. So one of the keynotes for this session actually talked about that, from learning from that experience. And I think, one of the some of the presenters included Dr. Alex McClellan, who has done a lot of work around HIV and criminalization. As you know, if the privacy of people living in HIV and their blood samples are not are protected or upheld, that can actually create a lot of issues, especially within the current environment where there are still people living in HIV facing criminalization within the country. Other presenters included Maureen Owino, many of you who may know from CAT. She was the former director of CAT, and she talked about how this type of surveillance actually further subjugates and oppresses specific communities, including the African Caribbean Black community, since HIV criminalization actually impacts a lot of men from that community. And Dr. Alexandra King, she is an indigenous physician and researcher. And she said, a few years ago, there actually had been some studies that were done where, the samples were anonymized, but then, they were taken from indigenous communities. But somehow, through the findings, they actually kind of label back, in terms of presenting the data, noting that in Saskatchewan, there's actually a very high rates of clusters where, there's HIV being transmitted in Saskatchewan a couple of years ago. And that was not done without consultation with indigenous communities. So that actually posed a lot of ethical concern. So this session was quite interesting, and I believe is still just a beginning of how researchers and community members are beginning to talk about this important topic. I'm going to move on to the next slide. So there was actually on the first day of the CAHR meeting conference, the health minister, Jean-Yves Duclos, was in attendance at the conference. And he actually held a roundtable with a number of researchers on undetectable equals untransmittable. So many of you may know that in 2018, Canada was the first country in the world to endorse U equals U. And, so many may consider Canada as a global leader in supporting, this newfound science. But in terms of implementation, there has not been a lot done in how, the government has actually, be it providing funding to community organizations to promote this message. What I know through my work at Prevention Access Campaign is the federal government is committed to supporting U equals U, but then they also wanted to, consult with multi-stakeholders, including researchers, to ensure that the uptake of the messaging is appropriate. And this is partly due to the fact that, there's still many systemic structural barriers that's hindering the HIV response domestically. So, many of the feedback from researchers also stated, addressing, the needs of key priority populations is, key. And then also there needs to be a lot of education to healthcare professionals, because many, doctors, they still don't know about U equals U. Many nurses, they still don't know about that. And how can we promote U equals U to healthcare professionals as well as allied healthcare workers? So this can actually, counter the type of systemic discrimination that people living with HIV still face when they enter into the healthcare system. And then also one key is how can we also promote U equals U beyond people living with HIV or people affected by HIV, because many of the public actually still don't know about this. So, stay tuned in terms of, hopefully we can, hear of some exciting, news from the federal government in seeing how they can support U equals U further moving forward. Okay. And then one of my other participation was I served as a co-moderator on a social sciences and oral abstract session. So this was focused on key populations, in particular on the sexual and gender minorities. I was stepping in for Shah's Islam, who was supposed to be the a moderator, but they weren't able to attend. So I just stepped in at the last minute. There were a number of interesting studies presented. In the photo, you would see Dr. Rola Hawa and Rola Hawa. And Dr. Hawa is a CTN researcher and based at the University of Waterloo, and not University of Waterloo, at Western University. And she does a lot of research around the Middle Eastern community. And for this session, she actually presented on, a study that she conducted for the community on Middle Eastern youth, in particular, the experiences of trans-identified Middle Eastern youth. And, some of the findings from the study really speaks to the gaps facing this community. As you know, OPA actually is, we're an independent network for all Asians, including Middle Easterns, and we're very lucky that in Toronto, ASAP actually has a Middle Eastern and Farsi-speaking program supporting people living with HIV. But in terms of the rest of Ontario, for Middle Easterns to talk about sexual health, gender identities, and HIV can be very challenging. So I wanted to kind of highlight, the importance of this research study. Okay, so and then next is many of you might have participated in a research study conducted by ACAS on E equals U. So it's on the awareness and acceptance of E equals U amongst East and Southeast Asian men who have sex with men. So this study was led by Dr. Nalini Mohabir of Concordia University. I was asked by ACAS to step in to co-present as a community member. And just want to acknowledge the work of the team, including that of research coordinator Michael Butak, and especially the community member, many community members who served on the advisory. So this is the demographic profile of the study. So the study actually had a survey as well as focus groups, and there's a pretty diverse breakdown. Majority of participants aged between 30 to 39, 90% identify as cisgender male, 30% identify as Chinese, 19% as Filipino, about 43% have resided in Canada for over 5 years. 40% possess a bachelor's degree. 67% said they have a family doctor. About 21% identify as living with HIV. And the income range for the participants range from 25,000 to 80,000 per year. And the presentation actually really focused on the qualitative findings. So including stigma. So I just want to read the quote to you. So, some of the participants really found that U has been life-changing in terms of the information they have been able to provide them and support their holistic health and well-being. So one of the participants said, so as a person in their 40s, I think it's hard to let go of the trauma response I developed to HIV. For example, HIV equals death. And there will probably be a bit of that response, despite of how much I learned about U equals U. It's like learning and unlearning anything else that I now question. For example, racism, internalized oppression, etc. I can unlearn, but a part of panic will always sometimes break through. So That's one quote. Some of the other themes that emerged from this study included, how U can be used as an education tool, as broader education helps normalize, HIV. And then, some participants quoted saying, I want to know if I could safely have sex with someone who is HIV positive if they were undetectable. So, that kind of shows that there needs to be further education within the community. Another theme that emerged include trust. So certainly in my community, the Chinese community, there's just a certain level of distrust of medical information in the public. So when we actually talk about ecosystem, how can we actually acknowledge there is this mistrust with the medical profession, and how can we actually perhaps using peer educators might be a good way to promote the messaging. And in terms of another theme is intergenerational and social historical factors. So one participant said that there's a lot of a whole spectrum of things need to happen, not just on focusing on the individual, but on the communal and the systemic. So, and this is related to also how we can, promote Yigoju more broadly and effectively. So the recommendations, they actually talk about how, the central role that's played by community organizations, and how organizations such as ACAS or ASAP or OPA can help push these messaging forward. And perhaps even, doing YouTube testimonials. As you know, as Asians living with HIV, we don't often get seen within the community. So how can we actually, put our faces or our kind of perspectives out there in a way so it can reach a broader audience? One participant said, these types of research is good, but it needs to go beyond the research study. And, just being able to translate the message effectively is very important. So some considerations for future research and knowledge exchange include potentially exploring, the level of awareness of equity amongst Asian international students, migrants, and other, intersecting priority population groups, and those, who test positive, are they actually hearing about equity from their medical providers? How does equity and gender changes within relationships, especially within kind of magnetic relationships, or what they say, zero discordant relationships. So if your partner is HIV negative and you're HIV positive, how does learning about you actually change the relationship? Does it have a positive impact? And what does you mean within the context of seeking or advancing health justice, especially for the Asian community? And lastly, I also participated in a session that's led by the Public Health Agency of Canada. This session was called Using Prevention and Treatment Innovations to Reach Communities. So there were a number of panelists, including many of you may know Dr. Darryl Tan, who works at St. Michael's Hospital, and he's a CTN researcher and has done a lot of work around PrEP and STI PEP. And so that is, I'm just noticing some a wrong wording on the slide on the bottom, so you can just ignore that, sorry. But in terms of the panelists, the one of the senior directors from Public Health Agency of Canada was there to welcome the audience. The panel was moderated by Dave Miller, who is a person living in HIV, and he actually is from the Indigenous community. besides Dr. Darrell Tan, there was a representative from GetAKit, which is she spoke on self-testing, and her name is Alex Munkston. She used to work at the Ontario OHTN, the Ontario HIV Treatment Network, and now she's with GetAKit. So Kenneth already spoke about self-testing earlier. GetAKit is one of the many programs that we're seeing in Canada that links people to self-testing, just, be it offline or, at a clinic or whatnot. And then there's also a nursing professor from UBC who actually spoke about, the linkage of care, and how can we ensure that, there's, we pay attention to addressing health equity and, engaging people living in HIV within that response. I spoke on U equals U. So, in particular about ways to address the existing inequities within the response. So how can we actually address, systemic racism and the lack of universal health coverage, in particular, encouraging the federal government to consider, implementing kind of a universal pharmacare, something that might be challenging to accomplish at this time, especially since the economy has not been doing so great. And, a lot of the provinces actually do not necessarily wish to spend more on healthcare. But just realizing, a more accessible, healthcare system, including medication, would be very helpful. And also the uptake of messaging, so while U equals U, I think many of us have heard it now. We also remember that initially when we talk about U equals U, it first reached, specific communities such as the gay white men community first, and then many of the racialized communities were left out. For some communities, such as, the indigenous communities, they find, U equals U still maybe a little hard to understand, because their worldview is not just talking about their viral load. They need to address health holistically. So how can we actually adapt U equals U appropriately? And I think the answer is, enabling, various communities to have that lead to, the opportunity to create and craft the best messaging for people to understand U equals U, while also considering the various social, cultural, systemic, and structural considerations. So I think I am just right on time, and that's actually all the report back I have to provide to you all. I also think I have said a lot, so I just want to give it back to Rodin, and thanks for the opportunity. And if folks have any questions, comments, now's your opportunity. Okay, thank you, Rodin.
Okay, thank Kenneth and Christian bring so much information and useful information for us. Yeah, and do you have any questions or any comments for the presentation, or have any specific question for Kenneth or Christian? You can just if you have any questions, you can just turn on your microphone, or you can also type on the chat section. Actually, I'm quite excited that Christian attend the conference and bring back a lot for us. Okay, anyone?
if people don't have questions, and if you're actually interested in, attending research, or if research is something that you're interested in, I would encourage that in the future, watch out for announcements from, conferences such as CAHR, and then they often offer community scholarships. So for me this year, I actually went to the conference, even though I initially thought I didn't have anything to present because I didn't submit a research abstract or whatnot. But I received a registration scholarship that was actually meant to be for the conference 2 years ago that took place in London. But due to COVID, and because that conference went virtual, that scholarship got rolled over. So I think, for me, I didn't necessarily know a lot about research when I first started working in the sector, but I, became engaged in the CHAMP study. That was the same study that Kenneth, and I got engaged in, and we became peer research associates. So definitely there was a learning curve, and it was through those studies and that, I and Kenneth were offered opportunities to co-present, if any of the abstracts were selected. And I think, slowly we became more knowledgeable in how to engage in research. Kenneth, I don't know, do you have anything you might want to add in terms of maybe perhaps kind of any ways how folks can become more engaged in research? If that's their interest, yeah.
It's just my view. If anybody like to participate in any research project, I think that is the beginning that you can be a little bit part of it, right? Try to reach out to Christian, to other people who are experienced in research, that will probably help you to get an understanding. For me, research is still very new to me, even though I participate as a peer research associate with Christian. I don't know how to word it, Christian. It's just that my heart or my passion is still more in the practical action side, right? More than research, which is very valid. Without research, we cannot put it into action. But for me, I guess I'm very impatient. Sometimes I just say, what is the action piece, right? So until now, I'm still finding a place or a piece where I stand in the research side. But I do encourage any one of you who are interested in research, do participate if you get any opportunity. And the other thing is about the scholarship. Next year, the CAHR conference is in Hamilton, Ontario. So maybe I'm wrong, but I think without the benefit of a doubt, they will give out a lot of scholarship, because this year they only have maybe 690 or 670 participants in the whole conference. I think they want more next year. So watch out the scholarship. They will give you maybe perhaps a complimentary registration, or even perhaps give you some traveling and accommodation for your stay in Hamilton. So keep an eye on it, and ACAS will send you all this information once it's available. Thank you, Christian.
Oh, awesome. Thanks, Kenneth.
Okay, I think not everyone will, familiar with the research, right? Because it's like something like a further study stuff. And as I know that some of the conference you need to register, or you have some new finding to announce. But like the conference the conference like CAHR, is everybody welcome? Scholar, yeah.
So I think CAHR, I mean, the conference, the primary audience, they are researchers. There are, students, let's say if you're a student or, like a graduate student or a doctoral student or a postdoctorate, you also see, some of them attend. But I think what I love most about these conferences is seeing community members being there, because in many ways, researchers, while they are working hard to explore specific questions, and they try to come up with the data so such data can inform specific programs or interventions or policies, whatnot. Many of them may not have access to, people living in HIV. So many times they actually do need to engage organizations such as ACAS or ASAP, or many would, there's this push for researchers to understand the role of the community, right? Like without the community, researchers may think they have a great idea, but without consulting with the community, they actually may or may not know whether the research question is sound. And beyond that is whether, conducting specific research, the prime, consideration factor is that they do not do harm to individuals, right? As an research subject or to the community. So I think, I do see this conference, there's quite a lot of emphasis that's been spotlighted on the role of the community. And I think that's quite encouraging, but I think we still need to kind of push more to ensure that our voices are not lost in the process.
Okay, and
I think definitely we need some more Asian representation, visibility, at least in the conference, right? There's a lot of young researcher that I know happens to be Asian background, but in terms of PLHIV, people living with HIV attending the conference as an Asian, I think the visibility is still very minimal.
Okay, and this annual conference will take place in a different city every year. Like this year, it takes place in Quebec City. And
yeah, this year is Quebec City. Next year will be Hamilton, Ontario, in April, I think 25th or 20th. I can't remember the exact date.
In London, or London, Ontario?
It's in Hamilton, Ontario.
Oh, okay.
Yeah, it's just maybe an hour and a half, 2 hours away from Toronto.
Okay. So then we are quite lucky because we are engaged in the association like ACAS or APHA. Then this is our access to the reference, to the conference.
Mm-hmm.
Kenneth, can I ask you one question? Because I know you actually were part of the community advisory for the new PhD study. So
right.
What was your experience, and maybe perhaps share with the group, actually, what's the process, and as you said, you feel like you're still learning about research, but do you feel your contribution on the advisory has actually helped shape the study in some ways?
I think so. Well, I don't know whether I did contribute anything, but I did at the beginning. I keep on saying that since day one, you is a good messaging, right? Good message to send it out, but we only know within our community, right? And even a few years ago, when I bring this use up to another a few of my Asian friends who are not living with HIV, you can sense their hesitation, right? Oh, are you serious? You know, that we're not going to contract HIV with, with having sex with people living with HIV who's HIV positive. You know, all the research and all the study there, and the hesitation is there. I don't know whether it's because our culture or because the message that we are doing right now doesn't reach out to a broader community. I give you an example. One of our community member who we are seeking to help him to go into long-term care home because of his age, because of his mobility and decline of the cognitive function. We applied to 2 long-term care homes, which is pretty well Asian populated, I would say mostly Asian, Chinese. And these 2 are the first 2 that turned his application down. Reason, excuse is he's smoking. So we turn around and say, okay, he's in a smoking cessation therapy. Now we submitted his application. And then they still turn him down because he's using a mobility device that is not accessible for the long-term care. But having this conversation with the long-term care staff and things like that, I can tell that this staff did mention 3 times about the health condition and the virus of this community member. So I think there is something against people living with HIV. Maybe I'm wrong, but as a team, when we have this conversation with the long-term care home, we both, me and my other colleagues both sense it. This is the case, that even we mentioned it, okay, the study of U equal U, we brought it up, and still, you can sense throughout the conversation there's some skepticism. So I don't know. Did I answer your question? I'm sorry, Christian, because I just get up.
No, it's okay. It's okay. It's fine. I think, you said you did provide some, insights, right? And I think a lot of times...
But that's why I think this research is very important, because we really want to hear it from the Asian community, right? How do they feel about it?
Yeah.
Learning totally. And unlearning, reach out to a broader community. I think that's what we need to do.
Totally agree. Thanks so much, Kenneth.
You're welcome.
Okay. So let's thank Christian and Kenneth again for bringing us so much precious information, and also report back about the CAHR 2023. Okay, and also I would like to thank all of you for attending, for your support. I really appreciate that. Okay, this is my first time, but I'm glad that we have a very good meeting tonight.